Welcome to another episode of Well-Adjusted Mama. I'm your host, Dr. Laura Brayton, and today's guest is Rebeca Four. Rebeca is the Director of Nourishing Wisdom Services based in Hoboken, New Jersey, and is a passionate visionary in the fields of normal pregnancy and birth, breastfeeding and parenting, and wellness through nutrition and lifestyle. She's a leading proponent of a maternity system that acknowledges the normalcy of birth, the importance of nutrition and environmental factors, and the crucial role of mental well-being and spiritual connection to the sacredness of pregnancy and birth. She has many professional qualifications, including the International Board Certified Lactation Consultant, Certified Birth Doula, Lamaze Educator, Hypnobirthing and Calm Birth Educator, among others. Welcome, Rebecca.
It's lovely to be here with you today, Laura. Thank you for the opportunity.
Yay. Of course. I have so much respect for you and what you're doing here in Hoboken, providing such a wonderful resource for moms during this phase of their life of pregnancy, birth, and early motherhood at your center, Nourishing Wisdom.
It's truly, as you know, a passion for me. The work that I do is really more than just work. It's really my life's passion. And I'm fortunate to find myself surrounded in our community by colleagues like yourself. You're someone that constantly inspires me with all that you do and provide and educate and help for women to have healthy pregnancies, healthy reproduction, and then to move into the phase of parenting and family wellness. So I feel very fortunate to have someone like you as part of the group for our community to provide wellness.
Thank you. So I know this is your passion. I would love for you to tell our audience of why you are so drawn to supporting the birth community.
Well, as I think most things with my life, it stemmed out of a personal experience. When I became pregnant with my daughter over 10 years ago now, I started to do research and try to educate myself about what my options were, basically. I mean, I had never been pregnant before, and the pregnancy had not really been planned out. So here I found myself in the state, and the first thing I thought of doing was trying to figure out what options were available for the development of a healthy pregnancy, what my birth options were. And immediately I was confronted with this attitude of not having a lot of information available for moms. And when I tried to sign on for my childbirth education, which coincidentally was a Lamaze series, when I was 20 weeks gestation, the hospital refused to register me. And their reasoning was that it was too early for me to get the information.
Oh.
And that just blew my mind. I thought, how can a woman at 20 weeks gestation be told that it's too early in her pregnancy to empower herself and find out what the options are so she can make educated, informed decisions? And that literally was a life-changing moment for me.
Mm. Wow.
And it's what led me, I mean, quite literally when I say it led me immediately to the path that I've embarked on for over the last 10 years. I knew it was like that light bulb moment, that Oprah aha moment that everyone talks about.
Yeah.
I just said, there's something wrong with the system. The system is broken when women are being denied information or told when they can have access to this information. And I just went to it, and I've never turned back. It was really life-altering, and it's what led me to where my life is right now and where my career is and the work that I do for the community.
Mm-hmm. Oh, that's such a great story. It's really powerful how we, get that light bulb moment, and it just becomes so clear what our life purpose is. And you certainly have been living that purpose now for, like you said, the past 10 years.
Yeah, and I truly feel blessed, and it's just another confirmation for me personally in terms of how I view my life experience, that everything happens at precisely the perfect moment in our lives if we're open to getting the message that's being delivered. Because I would have never, literally, 20 weeks before that particular incident happened, I would have never imagined that this is what my life trajectory would have been. I was in a totally different field in terms of my career and on a different life path. And just like that, in that moment, it just became clear. I didn't have the long-term vision, but I knew in that moment the essence of what I would do from that point on with my life.
Yeah, and that's all you needed, and you were able to take the first step and get all of these certifications that you have, and look how it's grown.
It's still, sometimes I pinch myself, and I, especially when I run into an old colleague or an old friend, and I think about what, that world or life was like for me beforehand and where I am now, and the level of real satisfaction that I experience on a daily basis in my life is just unparalleled. I mean, I couldn't imagine now that I'm here where I am and I get to do what I do, I can't imagine any other way of living my life.
Yeah, it's beautiful. For today's interview, I wanted to have you put your lactation consultant hat on, because I know you wear many hats. And we focus on lip and tongue tie, because I think there's a lot of information out there regarding that and how it can impact latch and other health issues. And you've done a lot of research and have attended a lot of conferences regarding it. So I'd love for you to share your knowledge with us and just tell us a little bit about what a lip and tongue tie is.
Absolutely. And here yet again is another situation where my own personal life experience led me down this road. So let's talk about the lip and tongue tie itself and what it is. And basically, when we're talking about the tongue, we're discussing the frenulum, the membrane, the fibrous membrane that's beneath the tongue that tethers the tongue, which is the only muscle that has a point that's not connected in the body, to the rest of the oral structure. And so frenulums are normal and necessary part of connective tissue. The issue becomes when in gestation, the proper recession that should take place does not. And so the frenulum becomes what we term short or thick, and that restricts optimal movement of the tongue, which is what we're concentrating on right now. I will speak to the lip in just a few minutes. And so that's what we call a tongue tie, is when that membrane, that frenulum, does not recede optimally during the gestation period. And when the baby is born, the way it impacts the baby is that it restricts full optimal movement of the tongue, which is absolutely crucial and essential in milk transferring. And we're not just talking about breastfeeding. It is certainly a bigger component where we're talking about feeding at the breast. But what we are finding is that with a significant number of babies, when this is present, it also impacts feeding at the bottle because it's impacting the mobility and the functionality of the tongue. So that's what we're talking about when we discuss the tongue tie. And for the lip tie, what we're discussing is the same membrane, but this one's found underneath the upper or lower lip. In most instances, you hear the reference to the upper lip tie, but while it is less frequently occurring, it is also possible that the lower lip frenulum can cause restriction. And the way that impacts feeding specifically at the breast is that when that upper lip frenulum, that membrane, does not recede properly, it impacts the way the baby is able to gape the mouth, so the ability to open wider is impacted, and also the intraoral vacuum seal that's necessary for the latch to be optimal. So a really quick, easy thing that your listeners can do to get a clearer understanding of why the lip would impact latch, because most people can understand and follow the consensus of why the tongue would impact it, but a lot of people are struggling with why the lip can cause issues that impact latch and optimal milk transfer, is they could do this quick exercise. opening your mouth as wide as you possibly can and feeling that sensation and observing what's happening biomechanically when you do that. And now closing your mouth, and again, opening your mouth while you're tucking in your upper lip. And when you do this, at least for myself personally and for those of my colleagues that have done this, when we're looking at the research study that indicates to do this kind of exercise, is that there's a lot of tension that's caused on the upper lip. For me personally, there's also tension in my mandible. And so when a baby experiences tension, when it gapes the mouth open to attempt latching, the mouth will not open as wide as it needs to be in order to get the profundity of the latch. So that is how the upper lip tie can truly impact breastfeeding. And this is causing the biggest issue right now because we do have some pediatricians and ENTs and other modalities of doctors that address these issues becoming more aware of the tongue and its impact in feeding for infants. However, they're still lagging in the understanding of the upper lip tie. And there's something I wanted to make sure that I talk about because it's very important, is that there's a big myth out there being promulgated, and that's that these frenulums will stretch or recede on their own. And there's actually a recent study coming out of Brazil that investigated the type of fibers found in these membranes. And what was found specifically with the tongue tie is that the type of fibers are collagen fibers. They're not mucosa fibers as has often been promoted. And this is a huge impactful finding because what we know about collagen fibers is that they are one of the strongest types of fibers that are available, are present in mammals. Just to give you an idea, leather is composed of collagenous fibers. And so leather is very tough and unyielding. And what we do know is that the collagenous fibers in live mammals is even more resistant to stretching. So that means it's even tougher than leather to get a stretch from a live tissue that's composed of collagenous fibers. And this is huge because one of the biggest things that's impacting the parents making a decision to address these issues is the fact that doctors are telling parents erroneously that these frenulums will match. And this particular study is showing to us that what we can hope to find is an optimal stretch of about 3%. And anyone that knows anything about the motor skills involved in the transfer of milk at the breast can certainly understand that 3% stretchability is inadequate in order to impact positively the latch. So this study is really, I'm hoping that will really start to move forward the appropriate information and science-based research that doctors need to avail themselves of so that they can make the best recommendation to parents on whether treatment is necessary or not.
And that makes so much sense that it would be collagen because, like you mentioned earlier, the tongue only has that one attachment. It doesn't at both ends like all the other muscles in our body. So, of course, you have to make sure it's strong. Exactly. Doesn't it make perfect sense when you look at it from a logical perspective? Right, and we're not doing that. And the thing is that there's this attitude of dismissiveness that's going on because the information about lip and tongue tie is not new. And this is what the doctors, in some instances are telling parents, which makes it very confusing for them. This is not something that lactation consultants or, the ENTs that are truly addressing and educating themselves about this issue or the oral surgeons that are addressing this are making up. What we find in literature when we've done a research is that
institutions like Stanford University have clearly published on their website that there's clear findings in the medical literature as far back as the 1700s that these two membranes or three membranes in the instance of a possible lower lip tie cause problems with infant feeding, particularly at the breast. This information is not new. What's happened is that, as you know, we lost breastfeeding for several decades in the United States, and with the loss of that, we also lost the precious information about lip and tongue tie and how it impacts breastfeeding. And what we do know when we look at the literature is that this procedure of releasing these frenulums that were causing restriction was actually being done at birth by midwives. And because of the total change in the culture of birth, this all went away. So it's not being taught anymore. The fact that it's not being taught does not negate that it's not new, and it has been a developing component of human development. I mean, it's the same thing with breech birth, right? Breech birth is just a normal presentation of birth, but because we stopped teaching the skills in medical school to obstetricians to be able to support and attend it safely, we're now viewing breech birth as an anomaly and something that's wrong. So it's the same correlation, unfortunately, that we're running into with the lip and tongue ties.
Yeah, I had heard that, when there was a lot more home births occurring, the midwives nail, and they would just go in and take care of those ties with the newborns.
Absolutely. It's fascinating. I had a client who was a mom that was coming to my store for several months, and her baby was a little bit older when I met her. He was 3 months old, and her husband is of Portuguese descent. He was actually, I believe, born in Portugal. And, I didn't know they had struggled with breastfeeding because she hadn't shared about that. She just came in for the parenting support. And then 3 months after I met her, she came in very distraught. And I asked her what was wrong, and she gave me some information about a recent doctor's visit. And every single thing she mentioned was a symptom of a possible tongue and lip restriction. So I asked her if she would give me permission to briefly check her baby's mouth. And, of course, lo and behold, what do we find? This baby had a completely undiagnosed lip and tongue tie. So I gave her the information about what her options are. I gave her my personal recommendations as to what to do and how to proceed. And when she told her husband, who recounted what was happening to his mother, she called me back elated. She was actually thrilled that his mother said that in her village in Portugal, women gave birth at home until 1959. And so up until that point, midwives would grow their pinky nails, and they would perform this procedure at birth for the babies that had the restriction. And she just found that so fascinating. And this woman, who's an academic, by the way, found it validating when she was making her decision to seek treatment. So yes, it's not a myth. It's actually a reality that while home birth was the norm, we had midwives that were addressing this issue very early on.
Right. They were looking for it, and it was addressed when the baby was like a day old. It was like, no need to wait.
No need to wait. There's an ENT in New York City. An ex-colleague of mine had a home birth with her second child about 9-10 months ago. And she was a trained peer counselor for breastfeeding. Actually, I trained her. And she knew what to look for, and she had breastfed her first child for several years. And so her baby was born in the middle of the night Sunday morning. So from Saturday night to Sunday morning, baby was born. She immediately knew there was something not working right with the latch. And she made a couple of phone calls to myself and a couple of other colleagues, and through a series of questions and symptoms that we checked, we confirmed that the baby had a lip and tongue tie. And so Monday morning, the baby was less than 36 hours, went into New York City and had the procedure done, and said that it took like 20 minutes for the ENT to get over the fact because she couldn't figure out how it was that she was there with a baby that was less than 2 days old. Because the ENT didn't even think about the possibility of a home birth. So it's just interesting how we've gotten so far away from what's normal that it took her 20 minutes of back and forth with the doctor because the doctor was stuck on the fact that how is it possible that your baby is less than 36 hours old and you're here in my office? And the mom finally said, I had a home birth. My child has this restriction. I can't breastfeed. Can we get past that? And can we just please do this procedure for my baby? Because the doctor was so stuck on that time frame and trying to figure out how it was possible that she was at the office that early.
Yeah, right, because, right now in America, home births are less than 1%. So I could see why that doctor would be like, how is this possible if this baby was born in a hospital? Because it wouldn't have been.
Right, because that's what's become the norm, right? The medicalization of the birth and all these timelines that are assigned to it is what's become normal. And when something that's actually normal progresses, we find that as the anomaly. It's just, it's really an interesting time that we're birthing in right now and have been for several decades.
Yeah. So tell us about how lip and tongue tie is diagnosed. It sounds like it's diagnosed as often as it could be. It might be getting missed in the pediatrician's office. So what do you recommend to moms that are wanting to get help?
Well, I think, the most optimal situation to have happen is for a mom to find an experienced, skilled IBCLC or registered lactation consultant. And I put the emphasis on experience and skill because while IBCLC registered lactation consultant is the gold standard for lactation skill and knowledge, as you know, we're all human beings, right? So we're only as well trained as we continuing education. So not every IBCLC is trained to adequately be able to assess for this. So that would be the optimal situation. But barring that, let's say in instances where there aren't enough IBCLCs available in rural areas or mom can't financially afford the private services of an IBCLC, what I would suggest to mom is to make sure she educates herself by doing the research first on what to look for to identify the lip and tongue tie so that when she does go into the pediatrician's office, she has a clear understanding of what her pediatrician should be looking for physically, structurally, what they should be palpating for, and what it looks like. What we're finding is that the moms that are empowering themselves before the visit, be it with an IBCLC or with a pediatrician, and know what they're looking for, they're having better results or being able to get an appropriate assessment and adequate diagnosis and referral. So I think it really starts with the empowering of the parents to understand exactly what this looks like. And in terms of assessment, there's some wonderful information available online from a couple of doctors, that are real pioneers in this area. And there are videos available where you can see what the assessment yields in terms of observing the frenulums and what's normal and what's considered to be a tie. So that's really something that, and I encourage that of parents for any situations, not just with lip tie or tongue tie. I encourage parents to be an active participant in the decision-making of the care of their children. So be it this situation or any other one, or a pediatrician or any other practitioner, I really think the parents should go in there well prepared to understand what the possible findings may be and what the outcomes of that might be. So that would be a good starting point. And here's the key. We want to really focus on symptoms because a lot of doctors are not properly trained through no fault of their own, just in terms of how things have developed in terms of the medical school and what's available with instruction. A lot of doctors are not well equipped or trained to be able to identify appropriately when there is a tie, particularly when there is what's been coined as a posterior tongue tie, where the frenulum is not visibly attached to the tip of the tongue, but it's attached further back along the midline. So an important thing, I think, to do is to speak to the doctors and insist on the symptom, because a lot of doctors will dismiss when they see the baby's ability to have partial extension of the tongue that there's any tight frenulum present. But if the mom persists for the doctor to investigate why the pain is persistent, why the trouble with the latching, why the baby is fussing, why the baby is arching at the breast, which are some of the things that we can find, why there's excessive spit up, why the baby falls asleep immediately and has a difficult time transferring milk, why the feed's taking 40 to 50 minutes at a time. If the mom persists on finding an answer from her doctor as to why these symptoms are present, we're going to have doctors that are going to start to look a little bit deeper, and that's a really important step for us all to engage in, to continue to ask why the symptoms are persisting, and so that the doctors can start to delve deeper and make the connection to the functionality of both the upper lip and the tongue.
You had mentioned that there's resources online to help a mom become more educated about lip and tongue tie.
Yes.
What's the best way to find that information?
There are several websites that I always use to give to pediatricians and also to moms. And the first one is Dr. Larry Kutlow. That's Kotlow. If you do a quick Google search under Dr. Larry Kutlow, he's a pediatric dentist out of Albany, and he's one of the pioneers, particularly addressing lip tie, which is really overlooked and dismissed. His website is very informative. It's got research. It's got articles written by him that have been published in peer-reviewed publications, and it's got videos that make it very clear for parents to understand what they're looking for. So that's a starting point. And then there's Dr. Bobby Gahary, who is an ENT doctor. And one of the things I really love about Dr. Gahary is that he's incredibly passionate because his knowledge about lip and tongue tie, he's an ENT doctor, came about from his own personal experience when his child was born and his wife was having grave difficulties with breastfeeding that couldn't be resolved. And he started hearing this information from lactation consultants, and he was open. He was a practitioner that had not had this information before, but rather than being dismissive, he did what I just previously discussed. He looked at the symptoms that were persistent in his wife and baby and how things were not working. And because of that, he remained open to the information, and he's now become a tremendous resource for families and colleagues alike. And his name is spelled Gaheri. He has a phenomenal blog that I highly recommend to practitioners and families trying to learn more about lip and tongue tie. He speaks about science, evidence-based information, but in very accessible lay terms that makes it easy for practitioner and family alike to find good resources. So those are two good starting points. And then if you also do a simple Google search of American Academy of Pediatrics, or shorten it to AAP, and lip and tongue tie, you will come up with resources that the professional body for pediatricians has, clearly identifying this issue of a short frenulum, either lingual or labial, as a direct impact to breastfeeding and other developmental issues when it comes to eating. And they also have information on their peer-reviewed journal, Pediatrics, of published studies there. So those are three good sources for parents to start and be able to weed out all the misinformation that's out there and to use it to bring it to their own doctors to continue to try and figure out together as a cohesive team what's causing their particular issues, and can it possibly be the lip and tongue tie that's present in their babies.
Mm-hmm. Oh, those are really wonderful resources. Thank you. So if it is determined that this baby has a lip and tongue tie, what's the next step?
Well, the next step would be either whether it's determined by a pediatrician and or international board certified lactation consultant, the next step would be to educate thoroughly the parents on what the possible risk factors are, not just related to breastfeeding, but other developmental factors as the baby grows. That's the starting point, right? And then once that has taken place, then to educate the parents about what the options are. And finally, to provide an option for a comprehensive care plan whereby the parents are ultimately going to make the decision which one of the choices they're going to have. So the most comprehensive way and permanent way to address this issue is through a procedure that's called a frenotomy. And a frenotomy is a procedure that's performed by a variety of modalities. It could be a trained pediatrician, though usually that's not the case. It could be a pediatric surgeon. It could be an ENT, a pediatric dentist, or an oral surgeon. And there are three ways to address this frenotomy. Frenotomy is the releasing of that tight membrane under the tongue and or upper lip, or if it also exists under the lower lip, so that there can be full extension and mobility of the tongue and lips. And the three approaches are cautery, which is one that I dissuade parents to consider because the temperatures for cautery are up to between 600 to 800 degrees, which means necessarily it causes a lot of collateral damage to the surrounding tissue. So that's really not, that's an option that is very seldomly used, but it's still available. And when parents bring this one as an option, I try to provide them with science-based information as to why this would not be a viable recommendation that I would personally make. And so the next option would be to have the frenotomy performed with a scissor, which is a clipping of the membrane that's done without any anesthetic. And the reason why I used to refer for this procedure before I became more knowledgeable about laser, the reason why I've stopped referring for this option is twofold. One is that I was finding that after these babies were having the procedure, after undergoing this, which is a stressful procedure for both baby and mom, though it's a very short time procedure, it's still highly stressful for both. Babies were not getting a full release. It seemed that practitioners that were using scissors, because there's greater likelihood of more extensive damage and particularly more bleeding, were not cutting enough. We're not releasing enough of the attachment of the frenulum, both under the tongue and particularly on the upper lip. So that's another option, and that's usually performed by an ENT in office. And then the final and most, in my professional opinion, based on all the research I've done and my personal experience with my own daughter, is a laser frenotomy, whereby the tissue, the membrane that's attached, is dissolved. And the particular laser, there are several options that I tend to refer for and prefer, is a cold light pulsating laser that's water-based. So there's no heat applied directly to the tissue as the procedure is happening. There's much less risk of bleeding. There's virtually no cases among probably 150 to 200 of patients that I've referred for the laser procedure of anything more than, one or two patients having had one drop of bleeding versus a significant amount of bleeding when I was referring for the scissor procedure. And so the laser procedure will dissolve the frenulum, the membrane, and will thereby restore full mobility to the tongue and the upper lip. But that's just one step, Laura, in the comprehensive approach to the most optimal way to address this issue. Because what we have to educate parents on is that this isn't all that's required. While baby has been eating with these restrictive membranes, baby has been engaging on a daily basis, many times a day. As you know, newborns and infants eat quite frequently. It could be normal to eat between 8 to 16 times in a 24-hour period. So every single time this baby has employed the musculature involved and required for eating, the baby has been using the overcompensation system. And so that means there's a lot of tightness and misalignment in what most commonly we find is the hard palate is very high and narrow, which impacts the ability to gape open wide enough and also for the profundity of the latch. So after the frenotomy is performed, hopefully with a very skilled laser procedure, then what you need to do is have a secondary step of stretching exercises that must be done. So moms dread them and babies dislike them. If the stretching exercises are not done, the likelihood of reattachment is very, very high. As you well know, severed skin, when the two severed edges come into contact with each other, the body that's a perfect design will work to heal that back together. And so this is the same thing that happens at the operative site. So mom needs to perform these stretching exercises several times a day for up to 4 weeks after the procedure. And in addition to that, she needs to have body work done to help the baby realign all the structures involved in the head and neck that impact directly or indirectly feeding function. And that body work is most optimally done by a very experienced, skilled chiropractic doctor who specializes in pediatric care, someone such as yourself, or in combination with a craniosacral therapist.
Yeah.
And craniosacral therapy is a series of movements that will enhance functionality. They evaluate and enhance functionality of the craniosacral system. It's very gentle touch, no greater than about 5 grams, which is about the weight of a nickel. And it's incredibly impactful, that along with chiropractic care, in helping realign all of the structures that are necessary for optimal feeding. The two most important being the hard palate and the mandible. And what we also are finding is that in a significant majority of these instances where we're finding a baby that has a lip and tongue tie, is that we're also finding some level or degree of torticollis. And so this is why it's so important for parents to understand that simply doing the frenotomy is not enough. It's sort of the analogy that I use with my clients that they really get is if I were to break my ankle bone and I had a cast for 10 weeks, once that cast came off, I have to have physical therapy in order to rehabilitate and be able to regain full function, optimal function. So it's the same correlation with having the frenotomy done. The procedure itself releases the tongue and the lip to now have the capability of optimal function. But now we have to go in there with the therapy and release all the misalignment from the compensation that has been taking place, and also in the case of the tongue, help retrain that baby to have organized suckling skills to be able to optimally remove the milk. So it is a comprehensive approach. It isn't just a one-step approach, but it's the only way to really achieve long-term, permanent, optimal results.
Yeah. It makes a lot of sense, and I certainly see that in my office, how structures can use some assistance with, like you said, reorganizing through chiropractic and craniosacral therapy.
Absolutely. I mean, with chiropractic care, we're talking about the muscular, skeletal, and nervous system, which are completely, the muscular skeletal system is completely involved in eating, swallowing, airway, all of the things that are present and necessary to have optimal function when baby is feeding at breast or bottle. or even as baby gets older and we're progressing into complementary foods. So that's why comprehensive care with chiropractic and craniosacral is really the best approach in my professional estimation. And it's what I always do as a standard of practice with my referrals. It's entirely, of course, up to the parents in terms of what path they decide to follow to address these issues. But as a professional and and from a personal ethical component, I feel that I have to give the parents the full breadth of the information of what I know to be valid in terms of what science is bearing out, and let the parent make the best decision that's going to fit their family. But it is my responsibility, as much as it's a lot, to give them all the information so they can make a properly informed decision.
Yeah, coming from a place of education as opposed to a place of fear.
Absolutely, absolutely.
Wonderful. Do you have any last closing thoughts you'd like to share with our listeners?
Just really for mom to listen to herself. Mom knows best. Mom knows when latch is not working. She really, truly does. We have taken the power away from women, from the language that we use when we say we deliver women's babies. We don't deliver women's babies except for the instance of a surgical birth. When there's a vaginal birth, mom and baby deliver that baby. So I think it really starts at that point with language. When a practitioner says, I just delivered your baby, and we start in that moment taking away from the woman her inner power and wisdom about mothering her child. So I invite mothers specifically to reconnect to that information and shut out all of the voices that are confusing out there, and to listen to herself, look at her baby. And most of the times women are the ones that know when something's not working. And if they feel it and they experience that feeding is not working optimally for mom or baby or both, then I really invite them to empower themselves with education and to not take no for an answer. And sometimes that's going to have to be reconsidering who the primary care provider is for that baby. And that's okay. This is truly important, and it's one of the early steps that can really empower a woman to be really present and feel confident in her ability to care for her baby. So that's what I would share with moms, because it's what I wish I would have had in my own personal experience. My daughter had a lip and tongue tie that was undiagnosed, and while I was able to, quote-unquote, successfully breastfeed for 2.5 years, my own child went on to have very significant developmental issues afterwards with airway and swallowing and eating and sleeping and all these other quality of life that really started impacting her well-being. And it wasn't until several years later that she was diagnosed. And even at that point, it wasn't a full diagnosis. And I wasn't really informed or educated on what the impact of this. So my daughter didn't have her lip and tongue tie addressed until she was 9 years old, because that information was kept from me. I wasn't given the necessary education that I needed to make an informed decision. So from that personal experience, I really invite moms to empower themselves with education and to seek out a practitioner that's going to support them and be able to make them an inclusive, active participant of the decision-making for the care of their baby.
Rebecca, thank you so much for sharing that information and for, really teaching moms to trust their mother's intuition and know that they know what's best for their baby.
Thank you. It was an absolute pleasure, Laura. Thank you for the opportunity.
Thank you. Bye.
Bye.